Hello, and thank you so much for joining webinar number 14 in our AFBSS webinar training series. Today's topic is outreach and engagement best practices, where we'll have a panel discussion. And now, without further ado, I'd love to hand it off to our presenters, Charles Robbins, Rachel Johnson-Yates, and Joseph Becerra.
I'm Rachel Johnson-Yates. I'm an associate principal with Health Management Associates. I'm joined by my colleague Charles, who is a principal out of our California office, and then Joseph from USC Street Medicine, who will introduce himself here in a few minutes. So we'll go ahead and go to the next slide. So today, just to kind of orient you to what it is that we're talking about, we are going to talk through an overview of best practices in field-based medicine. We're going to have, which is my favorite part, an opportunity to learn from some of the best in the state, if not the best in the country, at doing this work through our panel discussion. Thank you so much for joining us. There's so much exciting content today, and we're happy and excited to engage with you. Next slide, please. So in terms of our learning objectives, at the end of the session, we are hoping that you all will be able to identify some strategies that you can leverage in order to utilize existing behavioral health programs to design and implement assertive field-based SUD services without duplicating infrastructure that you already have. We're hoping that you'll be able to describe evidence-informed engagement techniques that effectively help connect with and retain individuals in care, specifically individuals that have complex intersecting barriers that include things like housing instability, co-occurring conditions, system involvement. And then we are hoping that you'll be able to apply practical relationship-based outreach approaches, including some flexible service delivery and culturally responsive practices that will help to improve access, trust, and sustain participation among populations that have historically been underserved. All right, so I am excited to hand this over to our friend and colleague, Joseph. Joseph, if you don't mind introducing yourself, talking a little bit about your background and your work, and then you can take it from here. Thank you.
Hey, how's everybody doing today? My name is Joseph Becerra. I'm the supervising community health worker here at USC Street Medicine. Been here for about 8 years now. Well, helped start the program about eight going on 9 years. So yeah, I'm glad to be here to speak with you guys. So here, USC Street Medicine brings medical care designed to meet the needs of people experiencing unsheltered homelessness to them in their environment, on the streets, parks, under bridges, wherever they are. This includes not just outreach to connect patients to brick and mortar clinics, but real medicine right there on the street. So what we're called is we call ourselves 100% backpack medicine. We're not a mobile unit. What we do is we drive around in our vehicles, which are trucks, with all our meds and our wound care and just everything else that we hand out and everything that we need, ultrasounds. We do everything on the streets and we go to them no matter where they're at, like it said earlier, whether they be on the streets, whether they be in the riverbeds, whether they be in the mountains, whether they be in the canyons. And of course, I'm in Los Angeles, so it's mostly concrete, but here in the city, we go everywhere also. Street medicine, primary care. We do health screenings, diagnosis, and treatment of acute and chronic diseases, birth control, STD screening, treatment, hepatitis C screening and treatment, substance use disorder, harm reduction, and medication assisted treatment, mental health disorder, long-acting injectables, LAIs, and other medications, wound care, point of care ultrasounds. Again, we bring it to them. That way they don't have to go to clinic or anywhere else. We do a lot of the long-actings, and they're amazing. I'll tell you that much right now. We've seen some really good work by using them, and we're one of the primary teams that use them quite a bit. We also got specialty services like the HIV care, behavioral care, street psych. We got social work. We got gender affirming care. We got enhanced care management. And we just started a new OB team where we see a lot of women, of course, but we've been seeing a lot more pregnant women on the streets, and we make sure that they get all the care that they need. We do the ultrasounds for them right there. That way they can see like where they're at in their stages of their pregnancy. Um, so we're able to do a lot of the things that you don't need to go to the clinic for, the brick and mortar, you don't need them. We come to you and bring it to you. Next slide. The scan that was just on the other one, it's just showing this coverage area. So it just shows all the things, all the ones in color. That's the places that we provide service. Looks small on the map, but it's very big actually. So we have many different teams. We have our South LA team, which is down below. We have our MacArthur Park team. Well, MacArthur Park team is starting next month, at the beginning of next month. It will just be located at MacArthur Park and around the area. Right now, we do service MacArthur Park, but that's with our CD1 team, which is in the blue, which is very big. We have our East Side, which is the green. We have our Mid City team, which is the yellow, and we have our Hollywood team, which is the purple up above. And like I said, we'll be starting a 100% Mac Park area team. So we'll be just in Mac Park and the surrounding areas. And of course, what we do is we do a lot of outreach. So we see what the people's needs are mostly, talk to them, become familiar with them. And that way they become familiar with us. They trust us. They see us in the area a lot of times. And what we are is really consistent. That's what our biggest thing is just being consistent in the areas that we go to. So a lot of times if somebody gives us a referral, we get a lot of different referrals from different agencies and partners. We do when we're there seeing a patient, a lot of times the patient will be like, "You think I messed up, or you think I got this bad? You should see my friend down the street, or around the corner." So a lot of times we do end up seeing people, not only the person there that we're going to see, but if it's an encampment, we'll sooner or later end up probably seeing everybody in that encampment, which can be 1 to 30. Um, Again, city and partners also give us referrals. Hospitals do a lot of referrals that either they discharge them to the street or they go AMA and just walk out by themselves. They try to find out the locations where they're at and where we can see them. The communities, just community mom and dad, grandma down the street can say, "Hey, I see this person that's always laying on the street next to the store that I go to, and they look like they need help. Do you guys know anybody that can help them? Well, we'll go out and help them." And external organizations like the LASAs and the PATHs and, the HOPICs and everybody else that's involved in our areas providing services. Go ahead and go to the next. So safety approaches and scene safety. So this is one thing that I'm real big on that I do a lot of trainings on, but this is something that being in the streets, right? Every day is a new day in an encampment. That's one thing we say all the time is every day is a new day. Just because you go one place one time doesn't mean it's going to be the same. It's not going to be the same a half hour later, much less the very next day. So we always got to read the streets, understand where we're at, understand what's going on around us. Always maintain situational awareness, which means most of the time when we go out, we're in a truck. It's either the CHW, it's a provider, whether it be a APP or a nurse, or we got many different visitors. We can have the psychiatrists or the social workers, but most of the teams will always go out with the CHW. And sometimes the CHW, maybe the people want to talk to the CHW more. So situational awareness isn't always just for the CHW, it's for anybody who's on the team. So everybody's always looking, making sure everything's going okay, making sure there's nothing going on. And a lot of times when we get to the encampments and we're talking to the patients, they'll tell us like, "Hey, today's not really a good day to be here. Maybe, this is happening or that is happening." One thing that we never do though is go alone. And that's one thing that I always say. And I know a lot of teams do, and I know a lot of people are okay with it. It's just not safe. It's not safe in so many different ways. Not only can, again, because every day is a new day in the academy, not only can it be some harm being done, but you just never know what people are going to say. If you're alone meeting somebody, we do have our ECMs that sometimes have to go out, but we'll make sure they're in public places around a bunch of different people and not alone. But whenever you're going into encampments, never go alone, never. Or never go into hotel rooms because we do a lot of hotel medicine too, because we follow our patients from the streets to no matter where they are at. If they go to hotels, which is like the Inside Safe programs, we still follow them. We've been following patients now for 8 years, maybe a little over, some that just can't get it, some that just don't want to let go, or some that just are too sick to. And they have problems with the hospitals and the clinics and different places like that. Oh, identity. I have my lanyard on right now. We never go anywhere without being visible. Even when I'm walking down the street, as you can see the guy in the picture here, this is Raymond, our social worker. He has a lanyard on, and he's going underneath the bridge in this picture. So even what I tell a lot of our people to do is, hey, grab your lanyard when you're walking, swing it, make sure they can see it. Because remember, most people who are coming to help most of the time wear lanyards. They don't wear badges or they don't wear other different stuff. You always, and then we wear our, USC shirts, USC street medicine shirts. So we're visible and trying to make ourselves visible to the communities that we walk in, the encampments. I call them communities because they are communities. That's where they live and that's where a lot of them spend all their days. We just make sure that everybody's safe all the time. So we have these code words that we have. I don't know how I am in time, but we have code words. Nobody ever carries a red pen or a yellow highlighter on us. So if we think that it's getting a little unsafe, somebody will say, "Hey, do you have a yellow highlighter?" Raymond, if I'm with Raymond, I'm saying, "Hey, Raymond, do you have a yellow highlighter?" And all that means is let's hurry up and try to wrap things up in the next few minutes. That way we can just get out of there. But if we ever say, "Hey, does anybody have a red pen?" That means drop everything and let's get out of there now. And there's so many different situations, but always maintain situational awareness. Never go by yourself, and every day is a new day. Go to the next slide, please. Strategies for engagement. So when you recruit somebody to introduce yourself, you're always saying, "Hey, this is Joseph, USC Street Medicine. This is what we do." Give them a breakdown. Is anybody interested? This is, of course, if we don't know the people, and entering new encampments that we never go to. And when we do, we always try to take things with us, because it's always better to come with hands full of stuff than empty-handed, right? Because then they feel more comfortable when you got water. Hey, is anybody thirsty? And right now, this summer, we know it's kicking people's butts right now. So we always bring water, hygiene kits, whether it be toothbrushes, razors, toothpaste. We have a lot of harm reduction. So if anybody ever asks for any type of utensils, which are pipes or needles or any of the other harm reduction stuff. We have it all the time. Tents, sleeping bags, when we have them. And right now we're lucky enough to have them, but they go pretty quick. So we try to give out as much stuff as we can. Snacks, always. People are hungry. People are thirsty. Be genuine. Be yourself because you don't want to go in there with a chip on your shoulder or acting like big and bad because they'll eat you apart because they understand when you're there for them to actually genuinely help or you're just there for the job. And we don't want to be the people that are just there for the job. We don't want to be the people that are just there pushy and saying, "Hey, do this or do that." No, it's 100% patient led and 100% all for the patients. So always be genuine. Again, we're always guests in their homes. Just like you're going to be offended if somebody just goes to your house, walks in and goes to your refrigerator, right? So we're always in their home. So we don't know what part of their home we're in. So we always got to ask to come in, always tell them who we are, and always just be genuine and just always appreciate how they respond to you. Go ahead to the next. So building rapport. Building rapport is just respect, right? If somebody says not today, okay, cool, no problem. We'll come back so and so day. Again, always ask permission to enter a tent, encampment, an RV, a hotel room, no matter where you're at, you're always going to ask permission because you're entering their home. One thing I always say is never make a promise. So show up when you say you're going to do it, right? But never make a promise because if you ever break a promise, they'll hold you to that. Only promise I ever make is I promise you that I really try really hard to help you. But, you know, under whatever circumstances there is, never tell them you're going to bring them this or never tell them you're going to give them that because when you don't, it's going to be pretty bad. Not, physically, but they'll always throw it in your face and they won't trust you. Trust is the big issue on the streets because we want them to trust us and we want to build that relationship with them. And you can't build a relationship when you start with lying, right? Or not, or breaking your promise or not coming through what you say you're going to do. So avoid making empty promises. Always be genuine again. Offer items even if they say no to the engagement, like the water or the food, and you can just leave it. Whatever they do with it, they do with it. It's not a waste because somebody will come along and grab water because that's, a valuable thing to always have. So again, just always be yourself, always be genuine, never give broken promises, and just love what you do because you'll meet a lot of people out there that are really, really thankful for just being around. And sometimes people just need a conversation, maybe not even medical stuff sometimes. So the relationships are big to us.
That was
No,
awesome. And I just really appreciate how I think you really struck such a beautiful balance of respecting and honoring and truly valuing the people that are served and the human beings that are
yeah,
being served by this work, with this idea of being real about the environment and the way that you spoke about safety. I just really I think that's something that everyone in attendance can take away, because you spoke about safety in a way that was not at all stigmatizing, but was rational about sometimes environments. Street medicine can be unpredictable, and so we do these things for safety, not because we're stigmatizing or judging this community, but because we want to be able to stay safe, and not do anything that's going to make a situation worse or put anybody in a situation that's not going to be safe, including the people we serve. So you did, that was awesome.
exactly. That's what I was gonna say. When I talk about safety, it's not just our safety, it's for safety of them too. Also, because just because we go into a place and are glad to see us, doesn't mean that everybody else around them is glad to see us. They gotta see
Right.
us and they gotta see the consistency about it. But yeah, definitely. Yeah, just always respect where you're at.
Yeah, that's awesome. Well, Joseph, thank you so much for that intro. I think was the perfect framing for our panel discussion. And luckily, as you all are probably hoping, Joseph is also on the panel, which is great. So let's go to the next slide. So I am going to let our panelists introduce themselves. So Joseph, you already heard a little bit about Joseph, and I'll start with Maria, and then we'll go to Sandy.
Good afternoon, everyone. I'm Maria Morgan, Assistant Medical Services Administrator for the County of San Diego, and that's just really a fancy way to say I oversee and administrate several of the local services that we have here in the County of San Diego. I oversee myself and my team oversee all of our narcotic treatment programs, along with our substance use outpatient programs. And today will be specific, like the reason why I'm kind of here on this panel is that the County of San Diego found it very interesting and curious about the BHSA policy in regards to a sort of field-based initiation of MAT and substance use treatment. Now, we've always known how effective targeted outreach could be. And so we value that service line. And so it made most sense to us to try to pursue something along those lines. So we can talk in this panel about how we decided to do that and how that works for us in the county. So looking forward to that conversation.
Hi, everyone. My name is Sandy Tutt. I'm a senior epidemiologist at Behavioral Health Services with Population Health. So I'm a part of a larger team of our public health services and behavioral health services of overdose surveillance and response team. So my team handles a lot of our data work and also our programmatic data and anything related to like overdose surveillance. So good to meet everyone.
That's awesome. Well, thank you. So with that, we can go ahead and drop our slides, and so that we can see the presenters. And we're just going to jump into some discussion questions. So with that, I'm going to jump in, and whichever of you feel comfortable starting. The first question is just really from your perspective, so we talk about outreach and engagement, and in these sessions, we almost like merge those words together, right? We talk about outreach and engagement, outreach and engagement, outreach and engagement, but they're actually two separate concepts. And how do you see those two different? How is outreach different from engagement in this work? Is there anybody that would like to jump in and kick us off?
I can start with something.
Yeah, thanks, Maria.
From a clinical point of view, I think there is a difference. I don't think you can really truly have successful outreach without having really successful engagement. To me and the teams that we work and the training that we do, it's really important. Engagement is about building that relationship that Joseph spoke so eloquently about, like building that trust, being somebody that's ever present, that you're showing up. It's the same face every single day. And even though the individual you're discussing and talking with is not interested in engaging in any treatment or services, you're still showing up. So you're sort of building that rapport and ensuring and just the connection. And I think they get invested in you showing up every day, and that sort of gives them a reason to be engaged with you. And I think, and just thinking about substance use um, disorders, and that it specifically, like, it really helps to have a community around that and an accountability around that. So if you're showing up every day as the outreach provider, you're sort of being accountable to them, and then they can start leaning on you and maybe, feel comfortable being accountable to you.
Yeah, I think it's a really big consistency is like Maria's saying too, is just being consistent, being genuine, like I was saying earlier, and just there's a saying that I always live by, and it's nobody cares about how much you know until they know about how much you care. And
Yep.
it's true. You can be the most educated person with all the degrees and not knocking degrees, at all. But you can go in there with all this education and all this big talk and all this, stuff that you've done for everybody and everything. But if you're not genuine and in there like you really care, like I said earlier, they don't want nothing to do with you. And I mean, why none of us here would want nothing to do with the person, right? I mean, so to me, it's just always be genuine, consistent, and allow them to dictate what they need from you. You know,
Yeah.
don't be the dictator of what they need. Even though we know, hey, if you don't take this is going to happen. If you don't wrap that thing's going to fall off. Or, I mean, you just got to let them dictate it and let them be the facilitator. And trust me, that trust just it melts. It's like, okay, you know what? You people really care. So.
And Joseph, this is maybe kind of a tough question, because I've been thinking about it, and I feel like it's a little bit hard to answer. But so when you talk about the difference between, coming to a person with this, like, if I'm probably not going to phrase this perfectly, but I'm coming to you degree first with all the books I've read and the letters behind my name and all of that versus a genuine engagement. Do you have some thoughts about how that might look different in terms of behavior? Like if you were to describe the difference in what that looks like, what do you mean when you say be genuine?
Well, okay, I'm from the streets, right? I was homeless
Mhm.
many years,
Mhm.
drugs, gangs, and all the other stuff. But there's just a difference of
Yeah.
somebody. I don't want to say you have to be there and have been through homelessness and, have been on drugs to counsel people about drugs, but there is something more genuine about understanding where you're at
Mhm.
versus a book smart about somebody else telling you where they're at.
Mhm.
There's more of a empathy, I guess, of, hey, you know what? I was actually in your shoes. I am you. And
Mhm.
and that's what I'll tell a lot of them a lot of times that I am you. The only difference between me and you is I chose a lot earlier to do this or do that. And that's what we're here for. We're here to help you understand that there's other ways or again, if you come in there like I said, you have to do this or you have to do that because I know because I'm the doctor, right? I'm the doctor, so you need to do this or your high blood pressure, you're going to have a heart attack, you're going to have a stroke. I think they know that. They know they're going to have a heart attack and stroke because they continue to either do drugs and not take medicine or, so I mean, I just, again, there's nothing, I mean, we have to have the educated people. I mean, it's a must, but I just think sometimes we forget who we are and
Mhm.
genuinely just try to, I'm the one who knows and you don't,
Mm.
people, especially, homeless, like, you know, people don't wake up in the morning and say, you know what, I'm going to be homeless for the rest of my life today.
Right. Right.
It's a situation. It's something that's happened and it's a start and it just increases and it increases. And the next thing you know, you're just out there and like fully out there and it's been years so I mean, and I have a lot of my providers that, the doctors and the PAs and the psychiatrists. I mean, we've got a really great core of people that show a lot of empathy and they learn also, like I said, they learn from our patients more sometimes than our patients learn from them. They really do.
I love that. And so it sounds like you're really describing humility. And what I really appreciate that you said was that it doesn't matter how much this idea that I know more than you know is not the right approach a lot of times. That what is the right approach is you are the boss of your own journey. You are the expert in your own life. I can offer information and treatment and options for you, but I have to truly honor the decisions that you make and meet you where you are in terms of your readiness. I think that's really beautiful.
Yeah, I think a lot of providers also, or whoever, whatever side you're on, whatever you're doing,
Hmm.
got to understand that just because they don't want the help doesn't make you less of.
Mhm.
You
Mm-hmm.
know what I mean? And I think we
Yeah.
always going with our feelings are in our emotions.
Yeah.
Like if we
Yeah.
don't help this person, if they don't listen, then I'm maybe I'm not a good, or maybe,
Mhm.
I'm not
Yeah.
doing my job. That's not about, again, it's not about you.
Yeah, that's great. Well, and that actually kind of is a really great transition to the next question, which is once you have made initial contact with a person, what sort of, and you both spoke to this a little bit already, but um if we take it even a level deeper, once initial contact has been made, what sort of strategies do you use? And the more specific you can get, the better. Like what are some things that have worked, have helped you transition individuals from outreach, right? So I've met you, where where we have a decent rapport. What sort of things have you used that have worked to try to get somebody into ongoing treatment and recovery supports without losing connection? What sort of things have you seen work?
Somebody else wants to go because I don't shut up. I mean, just
Well, I mean, you do have that very close experience, Joseph. So I think you have a very, very valuable voice in this.
Yes.
And I haven't done street outreach myself, but reached out to those who have and have gotten some really good feedback on this. And I think the piece I could add to this is one of the things that's really important is about really understanding their role in their community, right? It's a culture, there's subcultures, there's like that individual has been in that community on the
Mhm.
streets, homeless for some time. They may have built themselves up into a place of authority, whether it's like they bring in the drugs or they have the drugs or they're the connect or like there's
Mhm.
some role that they have built in that community, and it's important for us to not like rip them out of that role. It's more of an understanding of that role, and then possibly introducing pros and cons and like alternatives, or even I think understanding the role and what it means to them can help us as providers, like giving them an alternative. If they tend to be someone who likes to wash over all the animals, or they tend to be somebody who's like the middleman for all that, they're good communicators or whatever it is that really comes out as their strength that we can
Mhm.
understand, then we can really leverage that in connecting them to treatment or services.
So being really thoughtful about not coming in with this idea that you're homeless, being homeless is bad, let's get you out of homelessness, but really having respect for the survival skills that they've had, the
Yes.
community that they've developed,
Yes.
and the person that they've become to survive and sometimes thrive in those
Yeah.
environments, and
Yeah.
then using that as a foundation for that relationship, it sounds like. Is it,
Yeah.
did I hear that right?
Yeah.
That's awesome.
That was a great summary. Thank you.
No, you said
yeah,
it.
that was a
Yeah.
really good summary.
Yeah, Sandy and Joseph, what would you add?
So I'll give a scenario. One time we were at this spot that was really hot, and when I say really hot, I mean there are a lot of
Mhm.
activity, gang, drug.
Yep.
There was shootings there. We had some patients there, and I was with one of my providers, and she hits me in my hip, and she like pointed her eyes because that's the type of communication we have. We have like we
Mhm.
already
Mhm.
know, right? And I look over, and there's like these 10 guys walking towards us. And she's like, do we go? I was like, hold on. Because one thing also you don't want to do is panic. I do this safety training thing and I go through riding the wave and your emotion and a bunch of different stuff, but you don't want to panic. Because the moment
Mhm.
you panic, all hell will break loose, right? The moment you show that, hey, we're out of here and we're scared, another, you can really probably not go back as much because then they know that they can basically do whatever they want with you, almost not in a bad way all the time, but um so I said, hold on. So I seen them coming closer. So I walked in front, I started walking towards them, and it wasn't the best pleasant. I was like scared myself. I was like, uh-oh.
Yeah.
So I walk up and the guy goes like, "What the F are you doing here? Like, what are you doing here?
Mhm.
You don't belong here." And I said, oh, I go, I'm sorry, man. We're here. We're a street medicine team. We're here to help a few of the older people in the community. You have some people here that are really, sick, and we're just here to help them. And they go, how do we know you're here to help? And he goes, you know what? He goes, I've never seen you here.
Mm.
He goes, this is my block. I've never seen you here. I said, we
Mhm.
come here quite often. And I said, you know why you've never seen us? And he goes, why? I said, because we've never seen you. And he goes, huh? He goes, I don't know why that makes sense. He tells me. And I said, look, I said, we're just here to help the community. I said, do you need any help? Any of your buddies here need any help? And he, they were all like in their 20s and 30s. And he's like, no, we're all pretty young. And I was like, blood pressure or anything, can we check? He goes, you know what? I think I do have high blood pressure. And so I said, well, let us check you. And so like, it just came down the whole.
Yeah.
And then not only that, this guy happened to be, like Maria was saying, you don't take the power off anybody, right? He happened to be the person that controlled the street, whether it be because of drugs, it was a gang territory. But the crazy thing was, we went back, so everything was really good. He made everybody get their blood pressure checked, and you know, it was pretty funny, but we were there another time, and these guys pop out of a tent, and they weren't there the last time. We're like, who the hell are you guys? All this. This car pulls up really fast. He jumps out. His nickname was Spider. He jumps out. He's like, "What's up, Joseph?" He came up to me, gave me a big hug, like, "Hey, this is my doctors right here. You guys better not mess with them. You hear me? Matter of fact, everybody get out of here. You guys get your blood pressure checked. You guys get so." It was like Spider was our guy,
Yep.
and we could really help anybody because Spider said.
Yep.
And that's what I do a lot, right? I look at walls and I look at tattoos on people because in Los Angeles, San Diego, and different areas, in Los Angeles, it's real big because it's kind of like, the hierarchy of different stuff. The gang, it might be the craziest thing in the world, but it's really something to people that are on the streets, and that's where you're at every day. So, tending to know where you're at always, meaning by looking at the walls and seeing where you're at, which is the neighborhoods, because they're graffiti, the walls,
Hmm.
and tattoos. The people will put their gangs or whatever they represent on their arms. And I'm big, I've been around forever. So I know a lot of the big shot callers in the gangs, and I'll mention their name and they'll just look at me like, whoa, how do you know that guy? Like, and then they'll be like, oh, okay, like I can trust you because if you know him, like, so it's just different techniques that you use learning while you're in the streets.
Well, and Joseph, what you described, I think, maybe just if there are folks on the call that aren't very familiar with this work, that might, what you described might have sounded wild or reckless or just like what, to folks that aren't used to this. But what you were describing was recognizing that the person you were dealing with had some level of fear and some level of desire for self-preservation and some level of protection. And you had to figure out, how do I make the space feel neutral at worst and safe at best for this person, right? I'm understanding what their role and their goal is. I have to figure that out. And then I'm meeting them where they are, right? And I think that is that was what really a really great example, is that rather than uh reacting, you approached with curiosity, and you approached, but you also were smart about how you did it, right? If he would have escalated, I'm sure it would have been a different strategy that you
Oh
would have
yeah, probably would
employed
have been
in
in
that moment.
trouble.
Yeah.
Yeah, I'm sure it would have. Wouldn't have
Yeah.
been
No, but I mean,
good.
but the way you handled it, right? You could have come sharper at him, you could have run away, but you instead stood there and just talked with him as human to human, and he saw that and then de-escalated it. And I think that was great.
Well, another thing I always use is all we do is humanize humans.
Yep,
We're no better. We're no, like I said,
exactly.
I'm way no better than them. I just was lucky enough, blessed enough not to be them.
Yeah. I really appreciate that example. And the next question that I had was around whether you could share. I know this is something folks were interested in hearing today. Can you all share a specific example of how, when you all were building these programs, how did your organization adapt existing behavioral health program, whatever you already had set up? So maybe it was outpatient, maybe it was mobile crisis, something else. Um, to support this field-based work without having to build something entirely new. Because I think when folks are hearing about this program, it can freak you out when we all have limited budgets. This is hard work. We're trying to figure out how in the world do I make this happen? How have you all done that?
Well, I can definitely provide my example because I think it's a really good one for our county folks here that are looking to implement on a sort of field-based initiation of MAT. We, like I mentioned before, we were very interested in doing this service in our county along with the mobile NTP. So that's another piece of the puzzle that we were bringing into this county. But it just so happened, like as we were building our BHSA implementation plan for the state, we had an existing community harm reduction team that was funded by county funds for the last 5 years. And that program was sunsetting. And that program was really focused on housing. So it was a collaboration with our city. It was for specific shelter beds. And that team, although it was, staffed with like substance use counselors and peers and similar how we're going to continue to staff it, their real focus was just housing. So it was almost too easy, I mean, in many ways. And it was just a perfect opportunity for us to just transform that into a targeted outreach team. And so we've been in that same provider. So the county of San Diego, we contract about like 95% of our services out to community providers, and we love the work they do, and they're all so great. One of them happens to be on the call and has helped me with this. And family health centers is one that, so when we originally built that community harm reach team, we embedded it into a substance use outpatient program that family health centers were run. We separated it and now we're putting it back together. So the targeted outreach team that we're building is going to be embedded into a substance use outpatient program. So it'll be like very easy for this team to like connect with folks. If folks are at all interested in substance use treatment, can connect them same day, no problem. Not to mention, Family Health Centers also has a street medicine team, and they're a federally qualified health center. So they bring like just an enormous amount of resources to this work. And really, we're trying to be as flexible as we can with this team, just to like give those folks whatever services that they would want at a given moment. So we're really excited. The work hasn't even started yet. So the contract hasn't even been signed. We're looking at July 1st to implement this, and we're going to take this first year as a pilot and like really track a lot of different numbers. And that's where Sandy's team comes in, because we're going to use overdose data locally to be able to help direct where the team goes in their outreach efforts. So we're sort of going to be helping find where we can have the most impact in our community.
That's great. Sandy, is there anything you'd like to add to how your team will be kind of working to inform this work and inform this pilot?
Yeah, so San Diego County has overdose OD map, so overdose like mapping application program that was created by Washington Baltimore HIDA, and California EMS is actually submitting data automatically to OD map. So we actually have like, I think probably over like 95, 96% coverage of all the suspected EMS OD runs in San Diego County. Unfortunately, we're not able to like download that data to do more analysis, line data to do more analysis, but we can visually look at where the overdoses are clustering. And on the OD map application, we can also like make it into like a hotspot, so we can actually see like where areas in the county are experiencing overdoses. And these are almost near real time. So like some come in automatically, some like within 24 hours. So this helps us be more proactive than reactive to when, overdose clusters are happening or overdoses are happening, and also helps inform, us of like when to contact, public safety to also figure out like, hey, is there something that we need to know about the supply, so that we can also do better outreach when we talk to, our residents about what to look for or how to be safe when they're using.
And Sandy, what would you say to a county that maybe has a much less robust access to overdose data? Where could they put? So what you're describing is is following the hotspots, right? So, and hotspots similar, not that different to how Joseph was describing it. So where are people needing help? How can I use data so that my teams aren't just driving around aimlessly? How do I use that to figure out where we can focus in? Uh, what would you say to a county that maybe doesn't have that built out as robustly yet?
So I think the state of California, I think passed a law that all the local EMS agencies have to submit data to the state. So
Okay.
it's actually quite possible that a lot of the counties have access to OD map. So OD map can be signed up by any public health agency. They just have to request for agency access, and
Mhm.
they can see the entire country's like overdoses, including their own. So I think if they checked on OD map that their county would be there.
Mhm.
I know that our team will also use like medical examiners data, we'll use vital statistics data, death certificate data, and the hospital data, although those are like much more dated. So medical examiner data can be more recent because like I know
Mhm.
ours update monthly, but if you contact a medical examiner, they could probably give you more information. Um, up to date quickly, even though like they will be suspected cases because the confirmation takes a long time. And that's what OD map is too. I always tell
Mhm.
people it's suspected overdoses, like they're not confirmed, but it
Sure.
helps us get an idea of like where to go and where the problem areas are.
That's really great. And so this idea that you don't have to let the perfect be the enemy of the good, right?
Yes.
There's information out there where we can start, and housing instability and substance use looks different in different geographies, different cities, different towns. And so, what it might look like in San Diego is, going to be different than what it looks like maybe in Yolo County. There's all sorts of different presentations and cultures and ways people where people are and how they're living for the same population that needs help that could be served by these services. And I think that the use of data is really, really, really great here. Cool. I think we have time for maybe one more question. And so the question that this last question that I have here before we kick it over to open question and answer is, what are some of the most impactful ways that you have introduced flexibility into service delivery? So, Joseph, I heard you mention in your the first part of the presentation, having ultrasound technology in your backpack. A lot of people maybe hadn't thought of that. So it could be location, timing, communication methods. Um, it's really hard for us to start thinking outside of the box when we are used to things being office based. So what sorts of flexibilities have you introduced that when you've talked about it, people have been like, oh, really? Or what do you think you're the most proud of in terms of flexible service delivery in this work?
Go ahead, ladies. Anybody?
You got it, Joseph.
I mean, for us, it's just bringing the medicine to the streets. I mean, there's like you said, the ultrasounds, the meds. We carry a full med backpack that has over-the-counter meds, of course.
Yeah.
Um, any type for infections, for, headaches, antacids, just stuff that people might need right then and there that they don't have to go to the pharmacy for. It's a pretty big backpack though. It's like huge. We have all the wound care, so we'll live wound care supplies with people that they need. Harm reduction. I mean, I just think bringing the whole basically clinic to the person in itself is flexibility, right? I mean, they don't have to leave. We meet them. They know when we're coming. They expect us. We just continue to show up and show them that, we care. I mean, there's not for us, it's just something we've been doing for so long. It's just not even, I go to a lot of different places and I do a lot of different speaking, and I'm part of different organizations that everybody doesn't have, and we're just pretty blessed to have because we're able to do so much, and that's way above me. Um, they do what they need to do, and we're the ground people, and we just come through and do what we need to do. So the flexibility part is just that's 100% who we are and what we do.
And so you're really working to, for lack of better phrasing, cut out the middleman. So all of this, that we're used to, where you see the doctor and you have to submit the prescription, and then you drive to the pharmacy and you pay the money and you pick up the prescription and you take it back home, and then all of this process, you've cut that down to hey, you know what, I'm here with you now. Let's take care of this right now. And if I can't take care of this right now, I'm going to find somebody that can get you there and make sure that this gets taken care of for you, rather than kind of leaving people to flounder on their own in a system that's very, very complex.
Even with the big meds, the Biktarvies and
Mm-hmm.
everything else, the injections and
Mm-hmm.
everything that
Mm-hmm.
everybody uses, we bring to them.
That's
So
awesome.
yeah, they don't, I mean, we want to give them as much autonomy as possible
Mm-hmm.
and as much as they're able to, but if they can't, they can't, and we understand that. So we're just going to be 100%, to them everything that's needed. And some like going to the pharmacy, some will say, "Hey, send it to the pharmacy. I'll go. Like it's no problem." And yeah, we will. But a lot of the times, most won't, and we'll just take it to them and we'll give them what they need, and it seems to just be great like that. Yeah.
Well, and I think it really kind of gives you a vision of what healthcare could be like, right? There's so many things that we do because we've always done it that way. And I think what this group here on this panel has really demonstrated is we can rethink this in a way that is much more accessible and much more effective.
It's almost like village medicine. I mean,
Yes, absolutely.
And of course, like from an administrative point of view, it'd be nice if, the state can consider the services that we do like this that are very effective to be billable and reimbursable, because these are services that will absolutely like link and that are needed from the folks who need them. So that's obviously one thing we're trying to leverage the
Right,
BHSA is like try to find ways and to be able to capture some of this services in a billing way. But because it's BHSA and because we have freedom and flexibility, we don't want that to stop us from doing whatever it takes to be able to support these individuals. I
right.
think an example that Family Health Centers gave me about it was like doing groups like in the park, with
Mhm.
on a topic that that those folks want to learn about, not about like necessarily recovery and like how to stay sober, but like, current events or like something, just being like super creative about whatever it is or whatever information that you're bringing to them, just to get them engaged and get them talking, but to be able to have the freedom to do that and really meet them where they're at.
That's great. Um, One question I have, and I'm going a little off script here, so forgive me. One question, you've spoken to so many really wonderful techniques and ideas and approaches. And for anybody that has a question, feel free to still raise your hand, come off mute, interrupt me. But while we're waiting, how, what are some important ways that you have trained or supported your team members who are learning how to do this work? What are some things that you make sure that they know about, or areas that you make sure that we support team members who are kind of getting into this work for the first time?
for us, when even at the beginning of the interviewing process, we take everybody on the streets with us to see how we do our work. So, everything's on hands learning.
Yep.
They go from team to team, seeing what everybody else does different, how everybody else does it. And, that way they can develop their own type of skills when they're ready to be launched or they're ready to hit the streets themselves. So to me, it's just more important that it's, this is what you're going to do. You're not going to spend your time in an office, and you're not going to spend, I mean, unless that's what you're paid for, right? But you're not going to spend times having to do other things. You're going to have to be in the street, and you're going to go through the action. And hey, sometimes people when they come out for the interview, we interview them like this or in person, and then we go out in the streets. And sometimes they're like, "No way, this is not what I want to do," and that's fine. We don't want people to do something that they don't want to do, right? So
Right.
I feel that the best training is just to show them what they're going to be doing and how it's going to be done, and the people they're going to work with, and the people why they're doing this job, you know?
So Joseph, you said you even do that at the interview process.
Yeah.
Yeah, that's really
Right.
great.
Yeah.
That's really great.
I mean, we require motivational interviewing and like relapse prevention for all of our substance use outpatient providers, and so that trickles down a little bit to this work. But I think Joseph even mentioned like a safety training. I think that's a really important thing. But I mean, ultimately, it's like it's so challenging to find the right. It makes such a difference in finding the right people to do this work. Like they really have to have a passion and be able to be genuine naturally and be able to be non-judgmental and have that humility, and it can be difficult to find, so you really have it, and it's worth like looking for that person, because I think once you find them, then they're like committed to the work and they're doing it, and they're teaching you ways and how to connect with these folks. So um, I think staffing is really important.
Is there anything that you all do to offer ongoing, because when you work with this population, sometimes you see hard things, you lose clients that you really care about. Joseph, you brought up earlier, you have folks that you've been saying, gosh, if you don't take care of XYZ, it's this really bad thing's gonna happen, and then the really bad thing happens. What sorts of things are you doing to support your team members so that they can be engage in outreach and engagement in the way that they need to? Because the work is hard. The work is hard.
One thing I always remind our coworkers of is we hear, see, smell things that nobody ever will.
Yep.
And a lot of times us being in this field, you can't go home to your significant other and be like, hey, well, I just seen this limb falling off, or I just seen this really,
Yeah.
most of the time they're like, well, quit your damn job. We don't want to hear that stuff.
Yeah.
Like, there's
Yeah.
just so much stuff that, somebody else just can't handle. They're always like, I don't know how you can do that. We were just
Yep.
talking to a couple yesterday that his wife's in the field. And he's like, I would tase the kids or tase the people. Like, and we're like, yeah, that's why you're not working here.
Right, exactly. Yep.
But we always have debriefings. If something happens on the street, we debrief. We get the supervisors, we get the team, we get, a couple of people. We always leave it open. We have our own, like I said, social work. We have our psychiatrists, but we always leave it open to if anybody needs to talk or if something happens traumatically, we lose somebody. We have a wall that we put people's names on. You know, we try not to forget and we try to help those that need it a little bit more, and then we have a referral system too if it's that serious, that they can see the outside help with USC. But always try to make ourselves just present for each other, I think is a big thing.
That's great. I just want to say such a heartfelt thank you to the three of you for being on this panel. Y'all are
Thank you
awesome.
guys.
We have so
Welcome.
much that we can learn from you in this session, and
Oh, yeah.
with all of your work that you do, and just thank you for offering your time and your wisdom and your knowledge to us. You're incredible human beings, and the state of California is lucky to have you. And so with that, Meyer, back over to you.
Thank you so much for tuning into this webinar. If you have any questions at all, please don't hesitate to reach out to us at info@afbsstraining.org. Thank you so much and have a wonderful day.